Welcome to CVSA's second virtual presentation, CVS 101, The Basics Revisited. Before I introduce our speaker, I want to take care of a few housekeeping details as well as introduce myself. My name is Debbie Conklin. If you have contacted the office in the last 4 years, you have talked to me as I have been the program director since 2016. My involvement with CVSA started with organizing the Run for the Bucket in Wisconsin shortly after my son's diagnosis in 2005. In 2007, I joined the CVSA Board of Directors, and in 2016, I became the program director. For the duration of the presentation, you will all be muted. Please do not unmute yourself as background noise is distracting to both the speaker and those attending. If you are having trouble with your audio, you may consider using your phone to call in instead of using your computer speaker. Because of the overwhelming response to this event, there are over 300 people on this meeting. Unfortunately, that means there will not be enough time to get to everyone's questions during the Q&A session. Please submit your questions in the chat box. We will ask questions during the time we have available, and you can post them at any time during the presentation. We would like to welcome Dr. B. Lee as this month's presenter. Dr. B. Lee is a retired professor of pediatrics at the Medical College of Wisconsin and practiced at Children's Hospital of Wisconsin. Dr. Lee is an expert in cyclic vomiting syndrome and spearheaded the effort to define and standardize the diagnostic and management protocols. He has served as medical advisor to the Cyclic Vomiting Syndrome Association for over 25 years and co-authored the NASPGHAN CVS guidelines, as well as being involved in the adult guidelines and the pediatric guidelines update project. Dr. Lee has published extensively on CVS and given more than 100 grand rounds on this topic. I could go on for a long time about his many professional accomplishments, but most importantly, he has served the CVS community well by seeing over 1,200 CVS patients. He is rightfully known as the Emperor of Emesis. Outside of his professional life, Dr. Lee practices Tai Chi and enjoys spending time with his 4 grandchildren, one of which is only a week old. Congratulations, Dr. Lee.
Thank you, Debbie, for that nice introduction, and welcome to all of you spending time this afternoon. We are going to go on a whirlwind tour. And in fact, I have reviewed all of your 250 plus questions, and we will try to cover much of it and then some of it in the Q&A. Well, in fact, Debbie is correct. They have nicknamed me the Emperor of Emesis, and you can see this is why you have teenage sons who are good with computer and software, and he spliced me on the head of the last emperor of China. I have indeed seen almost 1,300 kids from 45 states and 5 continents. I do have to declare that I am a consultant for Takeda and GLG, and we'll discuss off-label medication. And of course, my son did me the favor and made me look really good and spliced my head on the body of Bruce Lee, my alter ego. Well, let's start and talk about CN, and he is one of the kids that taught me perhaps the most about CVS. And in each episode, he would be sick for 7 days out of every 21, in the hospital for 7 days, vomiting 150 times, accompanied by his parents, and would only wake up to vomit. So the 95% of the time, he was just lying there and then just wake up briefly, but wouldn't walk or talk for 7 days. On the 7th day, he would pop up, eyes would light up, and he would say, "What am I doing in the hospital? I want to eat. I want to go home." It was very frustrating to take care of him, and that's part of the learning process. We threw the kitchen sink at him, literally. We tried many things to stop the attack. In fact, we used ondansetron with lorazepam, that's Zofran, and Ativan, and we actually stopped one, but it didn't work again. We tried sumatriptan or Imitrex, and not much of a response. In fact, following the procedure with midazolam, ketorolac, he awakened transiently for about 45 minutes and talked, and then went back to sleep, and the episode continued unabated. We tried all kinds of preventative therapy. We failed with propranolol. And he was 3 years old at the time. That is something we use in the younger children, cyproheptadine, ibuprofen, and low-dose amitriptyline, which is about 1 per kilo. But when we went up to really high doses, 3 milligram per kilo, we prevented all attacks for 4 years. Then they recurred, and it required us to then go to a cousin of amitriptyline, nortriptyline, plus Depakote and anticonvulsant, and we prevented everything for 7 years. The good news, he's now 30. He's married and has children and is doing quite well. But this case illustrates that there is no test to diagnose it. We did many, many tests. He did have some esophagitis on biopsy from acid burning. He did have increased ACTH, cortisol, catecholamines like adrenaline, and that goes along with the Sato variant, in which you have high blood pressure with your episodes, but nothing to pin the tail on the donkey that said, in fact, he has CVS. And as you know, and too well know, CVS is often misdiagnosed and missed. So it misdiagnosed as stomach flu, food poisoning, but that just doesn't happen over and over like CVS. It's also been confused with reflux and blockage in the intestine, many other things as well. And finally, this case shows that we had to try many things until we came up with the right combination. And in fact, there is no one treatment regimen that works in all children with CVS or adults. Well, let's turn and talk about the history. And it really begins in English, at least, with Samuel G., an English physician, before there were pediatricians. And he described very important disorders besides CVS, also celiac disease and Kawasaki. And you may remember the game, Where in the World is Carmen Sandiego? My kids played it. And here you can see in red the case reports from most of the world and the support groups shown in green. And the only exception seems to be Africa. And indeed, in the US, the vast majority, almost 90%, cases are in Caucasians, and then there are a smattering in Asian Americans, Latinx, and African Americans. Well, if we compare CVS to celiac and Crohn's, we can see that compared to more famous cousins, CVS is as common as those. So prevalence is the percent in the population at any one time, and you can see it's in fact higher than celiac disease and Crohn's disease. If you look at incidence, is the rate of cases per year, new cases per year, you can also see it's right in the ballpark with celiac and Crohn's disease. So we should be paying more attention to it. Now, who is the most famous sufferer from CVS? And you can see I have a little clue there, the survivor of the fittest. Who might that be? Well, it is none other than Charles Darwin. And you can see here from his diary, it made me very ill with violent shaking and vomiting till early morning. And he had these recurrent episodes of vomiting that were not just from seasickness. They also occurred when he was in port. And when you look at his family tree, there's a lot of migraine, etc. And he looks very much like indeed he had this. Of course, we can't prove it, but it's very, very consistent. Well, moving up to the present, you will recognize Chandra Wilson, Dr. Bailey from Gray's Anatomy, who is our CVS spokesperson, and she came several years ago to speak at our conference and also site visited our program at the Medical College of Wisconsin. Well, let's turn and talk about diagnosis, clinical patterns, and features of CVS. Many of these you know quite well from your own experience. The first is the NASPGHAN Diagnostic Criteria. NASPGHAN is our professional organization of pediatric gastroenterologists in Canada and the US. And the most important point is that diagnosis is based on the history, taking a careful history from the family or the individual, not the laboratory testing. There are recurrent attacks, and we define that as more than 3 over 6 months or 5 total over any length of time, years. Discrete episodes, so they in fact will stop. They never last more than 10 to 14 days, and they can be as short as 2 hours, which is unusual, but it can be. And some kids do this and then can get up and go to school at 7 a.m., even after vomiting for several hours at night. And then well in between, obviously we define that as come down to baseline because some kids have other conditions as well. Very importantly is a stereotypical. And what we mean by that is these episodes are the same regarding the time of day that they start, the symptoms like the paleness and the tiredness, and then the length of time. The parents usually know, and so they can say, that's just like the last one. And that is a question parents say 98%. So that's almost like a good diagnostic test. Also, the vomiting at its worst can be very intense. And our average is actually 6 times an hour at the worst episode, the worst hour, the worst episode, which is every 10 minutes. And some are even going every 5 minutes. And some, once they complete the vomiting and empty the stomach, continue to retch at every 5 to 10 minutes. And so 90% do it at least every 15 minutes at the worst episode. And of course, there's no cause. And this is very frustrating, not only to you, but also to physicians who are looking for something they can identify. So the most important is that these episodes are nearly the same and that the vomiting is particularly intense. In fact, more intense than even children who have a blockage in their intestinal tract that requires surgery, because I have compared them myself. Well, if we look at this concept figure, there's the number of vomits on the upright axis, and along the horizontal axis is the 2-month timeline, or 60 days. And I want you to focus on the blue, and you can see the blue is vomiting once or twice a day, almost every day. And this is indicative of things like acid reflux, gastritis, food allergy, peptic ulcer. These are things that we can generally reach with the endoscope. So more than likely, this low-grade pattern, you can find something in the upper GI tract. But look at the other one that you're more familiar with this explosive type of vomiting in 1 or 2, 3 days, or can be longer, and then nothing in between. This is the pattern of cyclic vomiting. Now, it's not 100% because it can include some things outside the GI tract, in the brain, in the kidneys, in the metabolic system, and we'll discuss those shortly. I want to familiarize yourself with the variations in cyclic patterns, so to speak. So it turns out in my very large cohort of patients, about half have cyclic vomiting, meaning they're on a cycle that you can predict within a week, and half are episodic or sporadic. And those patients seem to be more triggered by stress or infection, weather change, or menstrual periods. The menstrual periods tend to be more cyclic, but the other ones tend to be more episodic. So, and the reason this is important, some doctors still ask me that their child that they're seeing is not on a predictable basis. Is this cyclic vomiting? I said, absolutely. There is another group with long cycle who do this every 9 weeks. I have another group that does it every 11 weeks. Some go even longer. And the reason I picked this out, so this is really a cyclic, and very often the parents come in with a calendar, and I've asked them to calculate from day 1 to day 1, and the interval is 61, 63, 62, almost on the dot. It is just uncanny. And this group is important because this one is very difficult to treat. In most of the situations, I can offer the parents the likelihood that 80% we're going to get pretty good control of this. But in this unfortunate group, it seems to be the other way around. We maybe only 20% that we really control it. And there's another unusual group we call cycle within a cycle. I've coined these terms, where these are mini episodes lasting less than 24 hours, but recurring for several days in a row and then nothing. So this would be like a child who wakes up at 3, vomits till about 9 a.m., then recovers by afternoon, can actually keep things down, evening feels pretty good. It starts over again the next morning, and then the next morning, and then nothing. And finally, there are some who have what is called coalescent. I will tell you, a lot of doctors don't like this term, but they don't vomit every day. But in fact, they have spells of vomiting, but when they come back to normal, they have nausea. And very often it's a morning sickness. It's more often in teenage girls. And so they just can't get out of bed every morning, but they feel better in the afternoon. And this would be a typical one, so-called coalescent CVS. Sometimes they can vomit occasionally. Obviously, if you're nauseated, you can, but it's not that spiked spell that we saw earlier. Well, this is from Dr. Fleisher, and you can see that there's a well period, then vomiting 6 times at the peak, and then back to normal. And then this highlights the fact that oftentimes parents and the child, teenager, and the adults with it say when they vomit, they don't feel any better. The nausea is still the same. And that makes it different from GI causes of nausea, because usually after you vomit, the nausea goes away for some period until things build back up. But because we believe the nausea is driven in the brain, it doesn't get better. Well, during the warning phase, that's when we try to get in medications, even oral, to try to prevent it from developing. If that works, you really don't have to take any maintenance or daily medication. If you're lucky enough that you can find one strategy like Imitrex or sumatriptan, that can work for you. During the episode, usually once it starts, we can't really do much. So we try to support the child or adult with IVs, anti-vomiting, pain medicine, sedation. And during recovery, we continue more of the same, but try to give some nutrition. And then in between, the so-called interictal in-between phase, when the child or adult is well, we use preventative therapy, which is taken every day. It includes anti-migraine, anticonvulsants, a lot of lifestyle things we'll refer to, and psychology. I'm going to emphasize that as well. Now I'll turn and talk about timing, which involves a 24-hour clock, the calendar, and seasonal predilection. More children begin in the early morning hours, sometime between 3 and 6 a.m., and not infrequently upon awakening. And we also describe that cyclic is about half and sporadic is about half. The most common intervals are 28 days, 14 and 7 days, but it can be 63 days. It can be 77 as well, as I showed. And finally, there are quite a few children, not all, who are better in the summer. And obviously there's less stress of school, fewer infections, but I believe the biggest factor is more sleep. And in fact, I've heard the story so many times where if I sleep till 9 a.m., and it sounds like a teenager being lazy, I will never get an episode. And I've heard that enough that I have actually modified the schedule with an IEP or 504 plan to allow them flexibility on the first period. Well, these are the key symptoms, and at 90% is the listlessness and the paleness. So they're tired, very exhausted and pale, sometimes looking like shock. Of course, nauseated, 80%, abdominal pain, loss of appetite, dry heaving even when the stomach is empty. And headache, we know there's a relationship to migraine, but affects less than half of the patients. This is a slide you probably familiar with if you have toddlers, and oftentimes the poor kid is faced the other way with a head over the commode. And usually completely worn out like this. And I've even heard this story from adults. They can be so pale, white as a sheet, looking like they're in shock. This is an autonomic symptom. Listless, almost as in coma, unable to walk and talk. So I've certainly seen parents who carry them into the emergency room just like a limp, wet rag, a 7-year-old who should be able to walk. They often have high ketones in their urine, and they require IV at some point, not necessarily every time, in over half, compared to less than 1% for stomach flu. And so the important diagnostic questions that an emergency room should be asking, or physician, has this happened before? Obviously, they're focused on this acute one. The child, your child may be dehydrated, but the key question to diagnosis, has this happened before? And if the response is, 5 times or 6 times this year, or 10 times over the last 2 years, one should definitely think about CVS. The second one, are these similar as to the time of onset, like early morning, how long they last, and how the child looks? These are home runs when it comes to diagnosing CVS. But unfortunately, these are typically not asked. Well, we'll compare childhood and adult here. And you can see in both children and adults, there are more women and girls affected. The age of onset, of course, is quite different, with adult onset about 32. But I will note, and there are 2 papers that indicate this, that some adults actually have started in childhood. So we call it pediatric onset adult CVS. You can see that the episodes last much longer in adults. So 6 days would be typical versus 1.5 or 2 days for a child. And you can see the coalescent, meaning nausea in between. Adults have that much more frequently than adults, so it's quite debilitating. You can see plenty of ER visits. And I want you to note that a significant portion of both children and adults have had unnecessary surgery. Usually it's removal of the appendix, gallbladder, and just looking around, looking for a cause of the severe pain and vomiting, but nothing is to be found because it's not an anatomic disorder. Adults have particularly prolonged and disabling CVS. Let's talk about what other things should be considered and other tests that need to be run. Well, as I showed, when you remember that spike pattern of vomiting, most of them, but not all of them, have CVS. So almost 9 out of 10 have CVS, but there can be other things, and some of them can be serious. So it's important that your physician take this into consideration. So that means that maybe 1/8, 1/10 of those that have that pattern that we outlined have a specific treatable cause that is not CVS, but looks and presents like CVS. So here are some of the serious things. And here are the numbers that I've seen. So malrotation is where the intestine, while the baby is in mom's womb, doesn't turn properly, and so it malrotates, and it makes it more susceptible to flopping over and causing a blockage, very serious, that can result in loss of the intestine. The next picture shows an ultrasound of the kidney drainage system, and here it's swelled. The dark is the kidney drainage system is enlarged because it's blocked down lower, and I've seen 12 of these cases of hydronephrosis that can look exactly like CVS. Unfortunately, I've seen in my long career a couple of children with brain tumors. This is an atypical presentation for it. And you can see on the right a Chiari, which is not a tumor, but it's caused by part of the brainstem pushing pressure down low. You can see at the end of the arrow, and it responds to a release by the neurosurgeon. And the kids, 6 of them had surgery and all improved. Well, here is the approach that we proposed in our guidelines, that if you meet the criteria that we showed in one of the first slides with a stereotypical pattern, one can do some screening laboratories, but if they don't have any warning flags, which we will cover in a second, they have most likely CVS, and then you can treat. So you don't have to do a lot of testing. On the other hand, if they're vomiting up bile, if there's severe pain or blood, further testing is necessary. If fasting seems to trigger it, or a high protein meal, these may be suggestions, especially in a toddler less than 2, that they have a metabolic condition and need further screening. And if their neurological exam is abnormal, they certainly need a brain MRI. And then if any of those are positive, then you have a specific diagnosis. It's not CVS, and it requires consultation with, of course, a gastroenterologist, a metabolic specialist, or neurologist or neurosurgeon. So in the past, we did this exhaustive evaluation that cost upwards of $20,000, including endoscopy. The blood work and urine should be done during an attack before any IV fluids are given, because those can normalize some of the things. And one also has to think in a teenage girl about pregnancy with HCG. But now, after our guidelines, what we propose is that one does screening labs, sugar, blood salts, BO and creatinine for kidney and upper GI, and then you can proceed to treat for several months or a couple cycles before further testing. Now, to underscore this point, a recent paper from my former institution, Lurie Children's, they found that in all of their testing, in I think close to 100 patients with CVS, only 4% actually had something positive that changed the treatment. So that means 96% the test was normal. So as you can imagine, a lot of unnecessary tests is done searching for obscure disorders that cause vomiting. And usually the testing is negative. I'm going to turn and talk about terminology. What happens over time to kids? Comorbidities, which is something I'm very concerned about, as well as subgroups. And some of these I will tell you that I'm virtually the only one that can talk about that, because I'm the only one that has enough of these cases that I can put them in different pots. Well, first of all, you should know that there is an overlap between CVS, abdominal migraine, and migraine headache. And in fact, neurologists will sometimes call this periodic syndrome, covering all three. And when we look at papers with CVS, this is my cohort, and we compare them with abdominal migraine, papers that describe abdominal migraine, you can see a lot of overlap. So in our cohort, 80% have abdominal pain and could be reclassified as abdominal migraine. Conversely, when you look at the old papers on abdominal migraine, a term more commonly used by pediatric neurologists, about half also vomit. So they could be classified as CVS. So how do we do it? We usually use the predominant, consistent, or most troublesome symptom. So if that's vomiting, even though they have abdominal pain, we tend to refer it as CVS. And if they have severe abdominal pain, but just a little bit of vomiting, that would more typically be classified as abdominal migraine. But some of it depends on whom you see. So if you see a neurologist, they more likely would use the abdominal migraine. But anyway, when you look at these kids and adults, they all have the same paleness, listlessness, anorexia, nausea, and light sensitivity. So they look the same, whatever their predominant symptoms are. So same background symptoms, even though the primary symptom may be different. So you can see here that the child holding the bucket, belly, holding the head. Very often with CVS, they will outgrow that and go on to have migraine headaches. But you can sometimes go through a phase where you get more abdominal pain, and then as you get older, you get migraine headaches, but it can go the other way as well. You can start with migraine and then go to CVS, and you can have 2 or even 3 of these simultaneously. So I do have unfortunate kids who have separate episodes of CVS, separate episodes of migraine headache, and also episodes of abdominal pain. So this combines an epidemiologic study. On the left axis is the percent. So CVS was about 2%, abdominal migraine about 4%, and migraine headaches about 11% in a Caucasian population in Aberdeen, Scotland. And a very, very well done study. And you can see that the age changes. The CVS were more the younger kids at the beginning of school, abdominal migraine about 9, and migraine headache mean of around 11 years of age. And so again, this conversion, in my experience, begins around age 10. And we have done a projection, formal projection study unpublished, where 75% developed this migraine headaches by college age. We know some will continue to have CVS in adulthood, but we don't know what percent. So people ask that. Unfortunately, I don't have an answer, but we will eventually figure this out. The other point I want to make, a very important take-home point, and you probably are aware of this, but CVS is not just a vomiting disorder. There are other comorbid complaints even when well. Anxiety and depression, very common, fatigue, sleep disorders, irritable bowel syndrome, constipation, postural orthostatic tachycardia syndrome, where you get faint when you stand up or go from sitting to standing, and then the nausea that we described. Well, we like to use animal analogies, and I use the octopus. Octopus have tentacles, and tentacles can be tenacious. Hope you like the pun. And what are the tentacles? Anxiety and 47%, depression and 14%. That's Dr. Tarbell's study. Limited stamina, half. And so these are kids who may be skilled athletes, soccer players. I've heard this story multiple times because it's an aerobic sport where they are great for a quarter or a half, but they have to come out and they're just exhausted. Or after a tournament, they have to sleep for about 2 days, this kind of thing. Or they run down towards the end of the school week. So they do well Monday, Tuesday, Wednesday, and then the teachers can see that they're kind of listless Thursday, Friday, sleep all weekend, and then do well Monday, Tuesday, Wednesday. Or sometimes by afternoon, their heads are on the table. Daily nausea we talked about, sleep disturbance, trouble falling asleep or staying asleep, and not easy to fix. This postural orthostatic tachycardia, where when they go from lying or sitting to upright, they may get dizzy and even faint. And they have done that even when we have screened them for this. The irritable bowel syndrome, and finally complex regional pain syndrome, which is unexplained limb pains that are intermittent. And interestingly, we have found that each child on the average has 3 of these in addition to CVS, in addition when they're well. So this just summarized Dr. Tarbell's original study and showing that this was common. And if we limit the cohort to school-age children, 59% met criteria for anxiety. And it runs in families, a little bit more on the mother's side. And we know that anxiety and panic can act as a trigger of episodes as well. And this has also been described in the literature and certainly from people and patients that I've spoken to. So what is the bottom line? Treating anxiety may be the key to treatment. I don't want to understate this because for years I had Dr. Tarbell working side by side with me in the clinic, sometimes seeing the patients together, sometimes before me or after me. And we worked as a team and found that alleviating anxiety was really critical. And it wasn't that CVS caused the anxiety, that anxiety seems to be part of this disorder and then can certainly make it worse. And obviously missed school then makes the anxiety worse. So dealing with this is, I think, a very important part of treating the whole patient. Well, this is also Dr. Tarbell's study, and you can see that the gray, the higher the number, the better the quality of life. So that's a gray. Those are healthy controls. And then going from right to left is organic disease like Crohn's disease, and then IBS in the light teal, and then in the darker is CVS. And so you can see CVS has the lowest quality of life, whether you look at the total score or the physical domain, emotional domain, social interaction, or school. CVS is the lowest and significantly different than controls. So interestingly, the quality of life correlated with the child's anxiety and coping ability, not the disease severity, like the number of episodes per month or the number of vomits per episode. It correlated with the child's anxiety and coping, and again underscores the need for a psychologist who understands this. So I just want to spend a moment on subgroups, and this is something I can talk about that most other people cannot. So most commonly, somewhere between 80 and 90% are migraine related, meaning that either the child or the adult has migraine, or for the child, more commonly, it runs in the family, more on the mother's side. And of course, we use anti-migraine agents. In the Sato variant with the elevated blood pressure, in the US, we tend to use amitriptyline. We'll hear more about this. In Japan, they tend to use more anticonvulsants like Depakote. In the CVS Plus, a term coined by Dr. Bowles, we use similar treatments. In those who have it with periods, so-called catamenial CVS, we use low estrogen birth control pills, sometimes for 90 days straight before allowing a period, or Depo-Provera. With those that have this long cycle, we don't know what the right treatment is, but we've had some success by loading them with a prepitant called Emend just prior to the anticipated time. So let's say it tends to come at 63 days, then maybe on day 61 or 62, we would start a prepitant. Mitochondrial, I know Dr. Bowles would say it's a much larger number, but in my cohort, these are the ones who had a proven enzyme deficiency. Again, we use amitriptyline in the mitochondrial cocktail, CoQ10 and riboflavin, and well as others. And for POTS, this is the postural orthostatic tachycardia, excess fluids, salt, fludrocortisone, and sometimes even beta blockers like propranolol. Well, I'm just going to show a couple slides on the cause. Obviously, we don't have enough time to really cover this in detail, but to give you an overview of some of the mechanisms. In the past, probably before CVSA was formed, we really didn't have any idea. It was really a black box, so to speak. And now we know that it's migraine related, but in fact, neurologists don't exactly know what a migraine is. They've described some of the EEG changes and know that the neurons are excitable, but what exactly is a migraine? We know the stress axis is involved, and that is the adrenaline that comes out in the fight or flight response. And we know this by the Sato variant, which the whole stress axis is overactivated. So you have high ACTH, vasopressin, cortisol, adrenaline. We also know, and this is Dr. Venkatesan's work, that the endocannabinoid system, which exists in your body, obviously that's what cannabis interacts with, or marijuana, also attenuates or suppresses or calms the stress response. And she's discovered some abnormalities in that system in adults with CVS. We know the autonomic system is involved. Of course, it's involved in stress, but we have found that children and adults with this are tuned with a high sympathetic tone, meaning more towards the fight or flight stress response, And now a new theme is emerging that they have poor vagal control, which is the calming side of the stress response. So that doesn't seem to be as effective or efficient. And then Dr. Boll's work showing that mitochondria could be involved. And I won't review that today, but how these pathways fit together remains unclear. We do have ideas. I can speculate on them, but we have to save that for another time. Well, we in, I think, 98 published a classic paper on the relationship between CVS and migraine. But I didn't realize it until later when I had to review the history that my idea was not original. It goes back to 1898. I was only a century too late. But obviously, there are similar symptoms between CVS and migraine. There are episodes on and off, so you don't have half a migraine, you have a full migraine, or you have nothing. And then the symptoms we talked about that are so typical, like the paleness and listlessness. CVS progresses to migraines in adolescence and adulthood. CVS responds to anti-migraine, so it barks like a dog. And there's a strong family history of migraine. And so when you compare a cyclic vomiting to those that have acid reflux, that low-grade pattern I saw, they have migraines about 14%, which is the same in the population, where CVS is way up there, 70, 80, 90%. And it's usually on the mom's side. We talked about CVS as a disorder of the stress axis. It's also called the hypothalamic pituitary adrenal axis. And we know in the Sato variant, which was described in the 80s, I haven't published this, but they have more severe episodes, twice as long, 100 versus 50 hours, and 2.5 times as much as vomiting. And then they have this whole stress axis that you can detect if you measure very early on, within the first 4 hours of the episode. The whole stress axis is turned on. CRF starts in the early morning when CVS occurs, and CRF stops the stomach emptying in animals. And so Dr. Taché has conjectured that perhaps CRF is maybe a trigger of CVS episodes. And we have actually shown in collaborative work in an abstract that CRF is increased during CVS episodes. I want to turn and talk about Cannabinoid Hyperemesis Syndrome, CHS, and raise a question if this is distinct from CVS, because I know you had a lot of questions about this, and many of you are confronting this in the emergency room and how they treat you. Well, the endocannabinoid system is a normal system in the body, and it has receptors CB1, 2, and the notion is that if you think of stress as a seesaw, it is one side of that seesaw that lowers the stress, but it also decreases nausea and increases the appetite, and it has been used to treat these issues in chemotherapy in cancer patients. Well, cannabis or marijuana, unfortunately, is a very complex substance, more than 200 constituents. THC is psychotropic, it makes you be loopy, and cannabis is much stronger as it's been bred over the last 60 years than it was in the 60s when Bill Clinton didn't inhale, pardon my commentary. And cannabidiol is the more therapeutic. It really has a growing evidence base in use of refractory epilepsy. And Dr. Venkatesan and I tried to work with the pharmaceutical company that is producing this and get them interested in a trial in CVS, but that did not come about. Well, the first case of CHS was reported in 2004, a very good case report from Brisbane, Australia. And these were young males using cannabis daily, recreationally. And during their episodes, they were typically in hot showers or hot baths. And they raised the question whether that is the hallmark sign. And it seemed to resolve if they got them to actually stop smoking marijuana, then it improved. Well, the Rome 4 criteria are diagnostic criteria for CHS, and they came out with this in 2016. Before, it was not considered anything separate. And they define that as stereotypical episodes resembling CVS. That sounds like CVS, does it not? And presentation after prolonged and excessive usage. So it seemed like it required 2 years and then very frequent usage, but really not defined. These were, in the red, are what we picked up from the literature. And it was relieved by stopping it. But how long, they never defined it in the criteria, and we defined it for the next slide as more than 4 weeks. But in fact, if you have episodes only every 3 months, then it should be at least a couple cycles or 6 months. So we thought that it should be at least 2 cycles or 6 months. And the supportive criteria was a hot water bathing, but you can see that this occurs in adults who say they've never been exposed to marijuana. And also I've seen it in teenagers, and I've seen it in young children who do not have any exposure to marijuana. Well, this is the data reviewing about 376 case series or case reports, and lumping together, they're about 30 years of age, also in adolescence. And 69% were in male. 68% used it daily over a 6-year period. 72% had hot water bathing versus about half in CVS. And only 16% met the Rome 4 criteria for CHS. And it's mostly because they didn't have adequate follow-up. So they didn't even follow them up for 4 weeks. So most of them did not meet the Rome 4 criteria. So they couldn't really be classified as CHS because they didn't have follow-up. So if you ask us, then for a bottom line, we would say, and this is the position we took in the adult guidelines below, is CHS may be a subtype of CVS triggered by excessive cannabis use. So we believe that it's not a separate syndrome, it's a CVS subtype with a different trigger than other patients. Well, talking about guidelines, I want to just give you the highlights from the pediatric guidelines and the adult guidelines. So this is the original guidelines. You can see published in 2008. And we have begun updating the guidelines in 2020, led by Dr. Kovacek, my mentee who is taken over my program. And so we recommended for children less than 5 cycloheptadine, which is an antihistamine, which increases appetite, and over 5 amitriptyline, and old antidepressant, but we use it in low doses, lower than antidepressant doses. And in both ages, propranolol, a blood pressure medicine for second line. All of these have been used to treat migraine headaches, interestingly, and they are really borrowed from neurologists. The abortive approach in children, we recommend triptans. And a couple notes I want to make. One is that triptans seem to work all or none. And by what I mean by that is if you give it, either it's a miracle drug or it doesn't do anything. It doesn't ramp it down. It's all or none. And I have unpublished data that indicates that it's more effective if the CVS episodes are shorter, less than 24 hours. It's much more likely to be effective. And it can be given intranasally. Unfortunately, sumatriptan has a very bad aftertaste, or it can be given by injection, and it in fact is more effective if given by injection, and obviously much more effective if given in the warning phase before the vomiting has started. Now, this is anecdotal. This is not from the consensus. but just my own personal experience, that occasionally some will respond to ondansetron given in the warning phase. And we also can give it rectally. It can be reformulated. And we also can give it as a dermal cream on the inside of the wrist. And in a few kids, I found it to abort the episode. Sometimes if we give sedation, rectal Valium is used for seizures. It's a sedative, anti-anxiety. We can nip it in the bud in a few. And in a few, these have been mostly teenage girls who have a severe abdominal pain. They're doubled over, and if it gets to a point, they will begin vomiting, that I've been able to treat this with hydromorphone, which is diluted. Unfortunately, in this day and age, given the amount of narcotic addiction that we have now in the country, that is very difficult to prescribe, and pharmacies will give a lot of pushback and often will prevent this. So this may not be feasible in most cases. Well, this is a table taken from our pediatric guidelines in 2008. So this is something you can actually share. It's on the CVSA website. You can share with your physician or the emergency room. Obviously, they have to prescribe it, but it includes what we think are the essential recommendations, which include going into a dark, quiet room with not too frequent vital signs, using IVs, in particular using a higher concentration of sugar in children, 10% dextrose, to treat it like a metabolic crisis. Of course, anti-vomiting agents, again, used in a higher dose, but this can cause arrhythmia, so it has to be monitored. And then sedation, pain relief, not narcotics, and then criteria for admission if there is clear severe dehydration or electrolyte abnormality. Well, here are the adult guidelines, and we just finished, and Dr. Venkatesan is the lead on that, and I participated as well, and you'll see Kathleen Adams' name there as well. And for preventative, the first line recommendation is tricyclic antidepressants. You can see the dose range, about 75 to 100, which is considered low dose from a depressant standpoint. And the second line are 3 anticonvulsants, topiramate, zonisamide, levetiracetam. The trade names are Topamax, Zonegran, and Keppra, and also a prepitant, which is an anti-vomiting agent, also called Emend. And those are the doses. But I will say for the tricyclic antidepressants and the anticonvulsants that the doses have to be titrated and ramped up very gradually to avoid side effects. Mitochondrial supplements include CoQ10. The standards that have been used are 400 milligrams for an adult, and the same for riboflavin, 400 milligrams for an adult, 200 twice a day. And those are the doses that have been used successfully to treat migraine headaches. And these have been studied in high quality randomized controlled trials and seem to help. Well, for abortive therapy, again, sumatriptan is used. Trade name is Imitrex, and the antiemetics, again, also. And second line would be a prepitant, and a 3-dose pack, 125, 80, 80, given on day 1, day 2, and day 3. So not all 3, but 1 dose per day for 3 consecutive days. Well, in the final section, I'm going to talk about general management principles, lifestyle changes, and again, prevention. And in more detail than we talked about beyond the guidelines. So the management principles are broad, and I think to take care of these patients, what I've learned from so many years, and learn also from Dr. Fleisher, is that you have to be comprehensive in approach, because there's so many aspects of this, including comorbidities, such as anxiety. And lifestyle changes we recommend. These are all things grandma would recommend, of course. Fluids, drinking enough fluids, long-acting calories, not meaning not the sugar ones, but more the protein and the nut bars that would last longer, exercise and sleep. And we'll go into these in more detail. But these also can prevent postural orthostatic tachycardia syndrome. So prophylaxis, we've talked about using anti-migraine, anticonvulsants, and mitochondrial supplements like CoQ10, riboflavin, abortive, but triptans work at about 70% of adults in migraine headaches, but probably only 50% of CVS, and that's been published from other work. Unfortunately, once the episode begins, it must run its course, meaning that you usually cannot stop it once it's broken through the abortive or preventative therapy. And so the only thing I have seen is sleep, which can sometimes reboot the system, so to speak, but that has to be deep sleep and requires heavy sedation, which is difficult to do on the ward, or even general anesthesia. There is a protocol to do that in the ICU. And of course, psychological therapy, cognitive behavioral therapy to treat the anxiety, which we know affects about half of the children, is really critical in my personal experience. Well, this is just to revisit the 4 phases of treatment by David Fleisher, the prodrome or the warning phase. So if you can recognize that you have warning, those are times when you can give abortive therapy. Then you do the rescue you saw in the IV protocol, the emergency room protocol, and subortive therapy when the vomiting stops, but they still aren't able to eat. Still try to give some liquid nutrition. And then treatment in between we call prophylactic to try to prevent the next episode. So that's something that has to take place daily or at least twice a week in the case of aprepitant. So here is a slide showing David Fleischer's wonderful placebo effect. So these are the number of attacks per year. So 36, attacks over a year is almost 1 every 10 days. Down to 10 times a year, which would be, every 5 weeks or so. And then after a consultation, but no, before any medical treatment, and you can see in 70%, the number of episodes went down. This has also been my experience when I enrolled patients in the randomized controlled trial of ondansetron, that we had marked improvement. But obviously, the fact that you're here means that you're probably not in this group. But it can have a powerful effect, maybe because it relieves anxiety. We think that having a diagnosis, having education, lifestyle changes, and having a written protocol alleviates some of the stress when you have to go to the emergency room. Sleep, a scheduled bedtime is important for an adolescent, absolutely turning off all the pinging electronics, computer, iPad, phone, using melatonin to help sleep, even in higher doses like 5 milligrams. Hydration, really the 8 cups per day for an adolescent or adult. Avoiding triggers, and we find them very commonly. We find sleepovers a common trigger, or a soccer tournament over a weekend with exhaustion. Lets the child fire off at 6 a.m. on Monday morning. In some cases, food allergens have been identified. And then the big 3 also triggers of migraine headaches include MSG, monosodium glutamate, used as a flavor enhancer, egg, cheese, chocolate. But I don't a priori eliminate those unless those have been shown by the parent's observation to be a trigger. We talked about the low glycemic index protein bars, and finally, exercise. Exercise, it doesn't feel good when you're nauseated, and when you don't feel good, you don't want to go out and do stuff, but actually light exercise increases mitochondrial function, which we think is important in these children, and you heard a lot about that from Dr. Bowles. Well, these are all the classes of things used in CVS. I've talked about all of them. Perhaps except autonomic stabilizers, the alpha-2 agonists, that would be like clonidine. They can be used as a patch. And prokinetics, those are agents like Reglan and erythromycin to speed up the GI tract. I haven't had particularly good responses to prokinetics, and the effect of autonomic stabilizers also has been mixed. This is a table of all of things, all the agents that have been published in children. So you can see the top three are things we refer to the primary drugs in our pediatric guidelines. But below that, you can see anticonvulsants, the next three, then a prokinetic, aprepitant, antiemetic, anti-vomiting, flunarizine, calcium channel blocker, mirtazapine, and tetracyclic antidepressant, and then the supplements. But in the red over here on the far right are randomized controlled trials, and we have no randomized controlled trials, which means we have no high quality evidence. Well, this just shows you that if you have a family history of migraine, that's abbreviated FHMIG, you are much more likely to respond to anti-migraine treatment, whether abortive or preventative. And so if you had a family history, you are 80% likely, had an 80% chance of responding to anti-migraine therapy. But if you had CVS and you didn't have a family member or yourself had migraines, you responded at a placebo level of about 30%, which those that ultimately had GI or non-GI disorders, they responded at a placebo response. So it's a striking difference. Does that mean if you don't have migraines that you shouldn't try an anti-migraine? No, I think it still may be worth a try, but you're going to expect less of a response, less likelihood of response. So family history of migraines predicts a response to anti-migraine therapy. This is work from McCallum's group in El Paso, Texas, in adults, showing the effect of amitriptyline in adults after 1 year in the middle column and after 2 years in the far column to the right. And you can see that the frequency of episodes per year went from 18 to 5 to 3 for over 1 year, 2 year, great response. Length of episode from 7 to 2 days long, and the number of ER visits, very, very important, went down from 15 to 4 to 3. So really quite successful response. This is not a controlled trial, so there's always a potential bias in this. So amitriptyline is the most effective, and I put up this first to show you that amitriptyline pushes 13 different buttons. And so that's why physicians refer to this as a dirty drug. It just, it's like a keyboard. You're pushing the whole key and making noise. And some of that is helpful and some of that may be harmful. And that probably contributes to its side effects. The one that may cause the most difficult side effects is the ACH, anticholinergic. So it's very important to try to minimize the side effect, to titrate gradually from low dose, something in adult like 20 or 25, and go up by 10 or 25 milligrams every 1 to 2 weeks to allow the body to adapt to it. So you can't go right up to the target dose immediately. The side effects are dry mouth sedation, but it can also cause an arrhythmia, so that if you have this prolonged QT interval on your screening EKG, or you have a family history of sudden death, this would not be a drug for you or your child. I want to highlight that there's also variability in amitriptyline metabolism. So it takes a lot of finesse to get to the right dose. It's usually by weight, so 1 to 1.5. So that means if you weigh 154 pounds, your target dose would be about 100 milligrams. There are slow metabolizers. So I've run into 4 children who cannot break it down. So they have a lot of side effects with amitriptyline. And at first I didn't know why, but then I did a genetic test and found they are deficient in their liver metabolic capacity. They were deficient in CYP2D6 and CYP2C19. And they could only tolerate either none or just a smidge of amitriptyline. I found more that are rapid metabolizers, meaning that when I get up to a dose, they don't have a therapeutic level. And so in one case, I had to go up to a super high dose of 4.5 milligram per kilogram to achieve a detectable level and efficacy. And the parents assured me they were giving it to them because oftentimes a kid won't take it. And that obviously is the obvious reason, most obvious reason. But in this case, it really took a super high dose because he was breaking up as fast as we could give it to him. But once we achieved a therapeutic level in the blood, he was fine. So there is a wide variance in tolerance. I want to highlight a Prepitant because this is the newer kid on the block. It came out in 2003 and now is in generic form. But a study from Great Ormond Street in London, that's their major children's hospital in England, used this protocol, using it as a preventative dose twice a week. And you can see if you're thinking about adults, more than 60 kilograms, you're using 125 Monday and Thursday, Sunday, and Wednesday. And 80% were substantially improved, 19% had complete stoppage of episodes, but most of them had a partial response. CoQ10, I think you've heard about this from Dr. Bowles. The point I want to make, and in this survey, so not a formal study, it had excellent side effect profile, no side effects, and had a similar efficacy to amitriptyline. In my own personal experience, it only works in very mild cases. It doesn't work in severe cases by itself, but we often use it in conjunction with. You want to get the high bioavailable form, and this is the point I want to make, that I've had kids in which it improves their physical stamina and improves their quality of life and their overall well-being. So one episode that is very clear in my memory is a 13-year-old boy who was very frustrated because he loved to play basketball, but could only last about 15 minutes, had to come out for 5, go back in, come back out, go back in, and all his friends could play for 2 hours straight without stopping except for a drink. And we didn't change his therapy, but I began him on CoQ10 and came back at the 6-month follow-up, and you could see his eyes just light up when he was telling me, "Dr. Lee, I'm just like all my buddies. I can play for 2 hours straight." And I won't say that this is a majority, but I would say a significant minority have improvement in school attention, improvement in school performance, and improvement in extracurricular and especially physical stamina during sports. I also want to highlight work of my colleague, Dr. Kovacek, whom you will hear from eventually. And this is her very exciting work on neurostimulation, neuromodulation, stimulation of the vagus nerve through the ear. So the first one is on abdominal pain, and the second one is a subset of that on irritable bowel syndrome. Well, this is what it looks like, and you can see that it involves putting electrodes on the outside of the ear, and then with a little battery pack and a stimulator that gives a pulse every 2 seconds. And so why this is a breakthrough, one, this is non-invasive because the other way, if any of you have children with seizures, in intractable seizures, they are putting implantable vagal nerve stimulators in the neck, but it involves surgery, whereas this one is not surgical, but it does have to replace, only lasts about 5 days. And so she is studying this on CVS. We'll know some results, hopefully in November. Well, I want to mention briefly my personal approach to the management of refractory CVS, CVS that just doesn't respond to any of the standard therapies that we have outlined above. What should a clinician do? Well, I think one has to think about perhaps missing an underlying disorder. And my test of choice actually would be repeating the abdominal ultrasound during the episode. Most often we're doing it in between when the child is well, but sometimes we can miss things that are only abnormal for a short while during the episode. And in fact, I have been fooled in my career twice. One with malrotation, which is a serious surgical disorder where the intestines have kinked over and cut off the blood supply. The second was a case of hydronephrosis, which is the blockage in the kidney. She had a history perfect for CVS. So this can be missed. I think identifying triggers, very often most often they're psychological. And it can be as simple as just the amount of school missed and the stress of that. Can be bullying, it can be death in the family, can be divorce or separation. All of these can be a trigger for this. I've seen chronic sinusitis play a role, but usually there's congestion, usually no fever, but it makes me think that sinus pressure can be a trigger. When it comes to therapy, I think one of the options that has definitely saved the patient, so to speak, has been the use of higher dose amitriptyline, but it requires close monitoring with EKGs and blood levels once you start to get above 1.5 to 2 milligram per kilo. I think aprepitant is now a very viable alternative. The main problem, it is expensive. I think originally it was around 200 per pill. Now I think generic it's about 130, but it's still very, very expensive. And so insurance companies often don't, but this looks like a very credible backup. And finally, I've used amitriptyline in combination. The combinations I have used quite frequently to control this is amitriptyline and propranolol. Oftentimes the heart rate goes up with the amitriptyline. I use the propranolol to attenuate that. Amitriptyline plus topiramate, amitriptyline plus Depakote have been helpful at different times. And finally, for those who have very long and severe episodes that are debilitating, like 10 to 14 days of hospitalization every time, we have used general anesthesia. There is one type that is used by anesthesiologists called dexmedetomidine, which does not require intubation. It's just a very, very, very heavy sedative, but it has to be monitored so closely that one has to be admitted to the intensive care unit. So in conclusion, CVS has on-off episodic vomiting with many, many comorbidities. So it's not a simple disease, it's just a vomiting disorder. And as you know, it's missed by many physicians and it's misdiagnosed by many physicians. The challenge is, and the reason it's misdiagnosed is because you cannot diagnose it by a test. It has to be diagnosed by that really careful history, asking if this is a recurrent pattern and if they are all the same, and you're looking for that spike pattern of vomiting, very intense, many times 15, 30 times over 1 or 2 days. That is classic. There are many multiple modes of treatment, and we usually have to use many of them in a comprehensive treatment program. So lifestyle alterations, psychological counseling, preventative medication, abortive medication, and finally a written program for the emergency room and hospital rescue when they need to come in. And lastly, I think the newer approaches, aprepitant's actually been around for 17 years, but really has not been used much in CVS, but now is getting much more play. There's a new anti-migraine agent, Erinumab, that's a monthly injection that might be effective. We don't have any data whatsoever. And then vagal stimulation of the ear, which you'll hear more about from Dr. Kovacic. So I thank you very much for your attention, and I wanted to make one more comment before we take a short break. And that is, now if you have listened, taken notes, and absorbed what I talked about, you actually know more than 99% of the doctors out there about CVS. And so, like knowledge and having something important, you have to use it with care. So, what I mean by that, I advocate families to use this not as a club to beat up your doctor, because no doctor wants to be put on the defensive, because they're responsible for thousands of disorders. And so they can't be perfectly up to date on 1,000. So anyone who knows a lot about one of the disorders really knows more than the doctor may know about that. But what you're trying to do with all this new information for you and handouts and protocols and guidelines from the CVSA website is to find a partnership and develop a partnership with a doctor. And that doctor may be a pediatric gastroenterologist, may be a pediatric neurologist, may be a pediatric metabolic specialist, general internist, family physician, neurologist, adult gastroenterologist for adult. It doesn't actually matter, but you want somebody that is willing to learn and willing to help and willing to do what it takes. And so sometimes it's more the right personality, because there are very, very few experts in CVS. I mean, you're going to hear from all of them, but you think of how many thousands of doctors there are are almost no experts out there. So I just wanted to give you that advice, because when you find the right partner, it can make the difference. And it may be a family physician that starts out knowing almost nothing about CVS, but's willing to be educated, willing to work with you or your child, and willing to go the extra mile. That's who you're looking for. I think Kathleen has a few words for you, and we will take a short break while she has a short discussion with you. Thank you.